We have a task before us today that is mixed in what I have to tell you. I'm going to try to weave together a sense of history so that we can understand, as George Santayana said, those who do not understand history are doomed to repeat it. We are 29 years into an epidemic that has changed the face of the globe and has changed all of our lives in ways I don't think we emotionally have been able to really catch up with. So I wanted to trace a little bit of history to set the stage with the idea that by understanding where the epidemic came from, where we're at, it will help us understand where we're going and what challenges we face. I also want to dedicate this to a couple of Canadian psychiatrists, Stephen Wu, who died of AIDS a long time ago, and who invited me up several times to talk here in Toronto years ago. And there was a Stephen Wu Memorial Lecture that I was fortunate enough to be the first annual speaker of that is, as I understand, still going on. And also to Ken Citron, who was part of our AIDS committee at the APA, who did a wonderful job of teaching and writing for us, and who died recently of brain tumor. So they're very much alive in my memory, and I think are part of the history of the work that I've done. So I'm going to start back before many of you were born, which is part of the issue we have with people now coming out. And as you can see from the slides, they're going to be stimulus slides. They don't have a lot of content. You have them in your packet. So try to stay with me to understand the conceptual model that we're trying to develop here, rather than the specifics. Many of you are not personally necessarily familiar with what was going on at the time, just prior to the introduction of HIV. We were in the middle of a pre-AIDS sexual revolution of the 60s and 70s. We had moved out of the early 50s and certainly the Victorian era of sexual repression. Gay liberation started with the Stonewall riots in New York in 1969, where a bunch of transvestite, cross-dressing gay men said enough already and began to rebel. And there was a big riot downtown Manhattan that really began to formally engage the public in a debate about who were gay men, what were they doing in our country, in our cities, in our towns, and how did we as a nation have to respond to it. So Stonewall began what we call the modern gay liberation period. Then in 1981, the Morbidity and Mortality Reports published a report of 5 cases of a bizarre pneumonia that had typically only been seen rarely in people with renal disease or immunological problems. And all the men who were described as homosexual, 2 had already died by the time the reports came out. The editorial note that accompanied the published report stated that the case history suggested a, quote, cellular immune dysfunction related to common exposure and a disease acquired through sexual contact. Even early on, as we began to piece together the epidemiology, many of us took note and said, this looks like a sexually transmitted disease. If it walks like a duck, quacks like a duck, looks like a duck, chances are it's a duck. Other reports were coming in from New York, San Francisco, and the title that was given to this cellular immune deficiency was gay-related immune deficiency. GRID. The word itself has a kind of harshness to it that really spoke to the emotional valence that was attached to it. What we understand now in retrospect is that 20% of the gay men who participated in a hepatitis B study that had been going on for a few years, they had banked all this blood from gay men from the 70s. And they looked cross-sectionally each year. Once the HIV antibody test was developed, they went back and looked at that banked blood. By the time the first cases came out, in some of the urban centers, 20% of the gay men had already been infected with HIV, although they didn't know it. There's an entire generation who experienced being ill from a disease that they didn't know they had actually acquired for many years. And that speaks to some of the invisibility and some of the responses of our culture. And the response from the government was to begin to issue warnings about the 4-H Club, homosexuals, hemophiliacs, Haitians of recent immigration, and heroin users. It was very hard to get away from the meaning of this to understand that it wasn't about who you were, it's about what you did and how you were in the way of this virus during transmission. And as we began to see the changing epidemiologic categories, the CDC consulted with many of us to think about how can we capture who was getting this disease. Remember, at this time, there were still mostly gay men who were appearing with these unusual lesions. This is a Kaposi sarcoma, which we almost rarely see now in our patients. This was a quite disfiguring thing. Think about a young, vain, there are a few gay, vain people, who were suddenly plagued by these visual scars and visual representations of this still as yet unidentified illness. In 1983, we gave a name to this called the HTLV3, which later became HIV. And it's just the virus, that's the virus there, it's self-identified. By this time in 83, there were 8,000 confirmed cases in the United States and 3,700 confirmed deaths. Much of the world was looking at us, wondering what was going on in the United States. Little did they know that they were soon to join us in the pandemic. And in 1985, the antibody test itself was developed, and that actually happened in a state lab in Massachusetts. And I was part of the gay lesbian counseling service that was asked to participate in preparing a pre and post-test counseling session. Now, why did we need that? Here we have this new virus, sexually transmitted through blood-borne products, blood transfusions, heroin, needle use. And how were we going to prepare people for the information that they had a lethal disease with nothing to do about it at the time? So we were trying to prepare people to undergo counseling, really basically trying to prepare them for the eventuality that they might have this illness, in order that they could then decide how to behave with the transmission behaviors that we were coming to understand. The problem was that there was a great controversy about this. There was no treatment. So the example that was being used was Huntington's chorea, 50% heritability. If you came from a family with Huntington's chorea, would you want to know that you had the gene or not, even though there was nothing to do about it? The question of no treatment had a great deal to do with the reaction of the gay community saying, we don't want to know, and live with the knowledge that we had this long-term progressive disease for which you can do nothing. Now, physicians, on the other hand, were seeing the explosion of these opportunistic infections. We wanted to identify people so we could pre-treat with some of the medications that would prevent people from going on to develop pneumocystis pneumonia. This controversy became quite political. There was a high mortality associated with this virus, and so people were scared. There was increased suicidal ideation among people who were seeing HIV as a death sentence. We worried about how many people would kill themselves before they came down with the virus. We didn't have a lot of data. This was not evidence-based. And there was this tremendous tension between gay advocates and public health officials who wanted to test everybody. There was a physician in Boston who sat on the Mayo's Committee of AIDS that I sat on in 1985, who wanted to place all gay men on an island in Boston Harbor and quarantine them regardless of their serostatus because they were the vectors of this. I was at a meeting of 35 people when he announced this plan, and to my horror, nobody thought that there was anything really sick and crazy about this in the room. People were stunned, I think, partly, and didn't think about the implications. The 3 or 4 of us in the room who were gay men were quite open about our disapproval of that plan. I said, I won't go. The gay-related immune deficiency thing, however, started some conspiracy theories. In any population, there are some people who will move to that side of the story. This was a government plot to rid the society of homosexuals. This had echoes of Tuskegee experiments, syphilis in the United States. The tensions grew. And one of my patients who I started to see in 1984 and continue to see to this day told me this, and I wrote it down then, and it still has profound meaning. It was as if we had all been playing in a beautiful field, finally free to be ourselves, joyous in the love and sexual freedom we had struggled to proclaim in the midst of an intolerant society, when some unseen wave came across the field and all my friends went down. For some unknown reason, I was left standing alone, surrounded by my friends, my family lying dead around me. This man is now 59 years old. He is HIV negative. His life stopped at this point. He had been a highly respected, highly regarded professional, and although he continued to work, it was as though someone had ripped the shell off of his body, and it was walking around, but his soul and his inner spirit had died. And to this day, he is quite limited in his interpersonal relationships. Everybody recognize this guy? This began to bring awareness to the world. And in 1985, finally in his last stages of illness, American Hospital in Paris announces that he has AIDS and he dies shortly after. Hollywood becomes involved, and this becomes suddenly a cause célèbre. But it also incites homosexuality and homophobic responses in the press, and there's the rise of this us versus them. And this is a key issue for us today. The so-called innocent victim, meaning that the rest were guilty. Falwell said AIDS is the wrath of God among homosexuals. Reagan's communications director, Pat Buchanan, argued that AIDS is nature's revenge on gay men. And if those of you who have recently seen the reports from Haiti about the Haiti's devastating earthquake was a result of the pact with the devil for having helped the French, or fought the French. This began the public outcry, silence equals death, and the development of groups in New York City, San Francisco. Shortly after, all the urban centers developed community-based organizations that began to take issue with how are we as a community going to respond to this. Writing in the Washington Post in late '85, Representative Henry Waxman, who has been our local hero in the United States, shepherding through the beginnings of a healthcare reform, which some of you may have heard about. I know that that's all old news to you guys here in Canada, but for us in the United States, this is big news. It is surprising that the President, Ronald Reagan, could remain silent as 6,000 Americans died, that he could fail to acknowledge the epidemic's existence. 1985, he'd been president for 5 years, had not said a word publicly about an epidemic that was killing thousands and thousands of people. 10 women came down with toxic shock syndrome. The CDC issued a warning, and Reagan was on this like a hot potato because it had something to do with political cachet. Then we enter the era of the Ryan White, the called innocent victim, someone who as a child represented how this was parlayed through the bloodborne mechanism of disease, and the split between the Ryan White innocent victims and the gay community was quite palpable. All of a sudden we have a child who comes down with this, and now the government gets motivated and we get the Ryan White bill, which begins to fund community-based organizations and even mental health work in the United States. And then in '87, with the first antiretroviral treatment, AZT, there begins to become a little bit of hope. What was going to happen now that we might have a treatment? Many of us were a little alarmed by the rapidity with which this drug was being administered. Some of us who had been thinking about viruses and mutations were concerned that single therapy might be problematic without more evidence. And so many of our patients refused to take this drug, even though it was available, and many decided that they would go ahead for it as they began to get sick. And what we found is that for some people who took the drug, they had a benefit for about 18 months or so, and then unfortunately progressed more even rapidly to an early death because of the mutation and resistance that had been developed. HIV becomes an issue in the heterosexual and minority communities, and suddenly this is no longer a gay-related immune deficiency. Suddenly the world wakes up, and interestingly enough, even though in the rest of the world cases had been defined and experienced only primarily in the heterosexual community, that hadn't really affected the United States view, the Western world's view of HIV. And then in 1991, Magic Johnson announces he's HIV positive. Magic Johnson, some of you may recognize now as a formidable basketball player in the United States. And Magic Johnson both showed people that this affected minority communities, that it affected heterosexual men, since he had been more than proud of his multiple dalliances, and acknowledged that people were having sex publicly, talking about the multiple partners he'd had unprotected. He also went on to say that at times, though, that he had cleared the virus, and so he was perfectly healthy, and that put us back quite a bit in terms of the minority communities. Remember, when you have a young African-American boy growing up in the inner city ghetto and he sees someone like Magic Johnson having made it, making millions of dollars a year, and he says, I cleared the virus. What's the message to these young people who will take risks to take that 1 in a million chance to become like Magic Johnson? This mobilized gay and lesbian communities even further. They began social activism in response to the non-government response, development of CBOs, as I said, and the Names Project, which was a category of work that had never been seen in the United States before. Here is a slide of the Names Project. These were individual, each of those panels that you see separated on the, I don't know if you can see these lines where people could walk through, okay? There were thousands and thousands of individual panels sewn together, laid out on the mall that stretched literally thousands of yards. And for those of us who went to the First Names Project in DC, it was profoundly moving to walk amongst these things and to see scattered about, there were thousands of people on this mall, silent, walking, people comforting each other, kneeling by pieces of fabric that were memorializing people they'd lost. Many of us walking through here recognized the names of people we had lost contact with and found out through this Names Project that they had died. And I remember sitting with my partner at the time, finding out that one of our close friends, we had moved from California in 1980 when I finished my internship and had moved back to the East Coast and had lost touch with a couple of the people that he had grown up with in the Bay Area. And this was how we found out about what had happened to them. Think about how that sits in the minds of people in my generation and of the people we then had to help take care of over the last 30 years. I will try to get through this without losing it. Paul Manette wrote a story about his lover, Roger, that explains, I think, the affect and the mood of the country at the time. The story that endlessly alludes to the decorum of the press is the death of a generation of gay men. What is written here is only one man's passing and one man's cry, a warrior burying a warrior. May it fuel the fire of those on the front lines who mean to prevail, and of their friends who stand in the fire with them. We will not be bowed down nor erased by this. I learned too well what it means to be a people, learned in the joy of my best friend, what all the meaningless pain and horror cannot take away. That all there is love. Pity us not. This became the rallying cry for the gay and lesbian community. It was a time when gay men and lesbians that had been somewhat parted in their initial coming outs began to join forces, and there's no way that gay men cannot acknowledge the extraordinary interaction and appreciation of the lesbian community who were not personally, in terms of their own health, being affected by HIV, but had really rallied around their brothers and became caretakers of their wounded compatriots. This experience of unremitting grief, my partner, now husband in Massachusetts, we've lost 50% of our friends over the last 30 years to HIV. I still find myself thinking about people that I didn't have time to grieve. When I was a resident in 1981 in Mass General, and I started to do work with this, I was the first psychiatrist to actually see a patient at Mass General with HIV, with AIDS at the time. I got warned from the senior faculty to not get involved and associated with this disease, that it would, quote, ruin my career and make me untouchable in the academic community. I fortunately had one supervisor who later became chancellor of the University of Massachusetts, Aaron Lazar, who I obviously adore, who said to me, life is short. Does this matter to you? If it does, don't listen to anybody else. They don't know anything. Do what moves you. And Aaron has remained a very powerful supporter. When I went on with my husband to adopt 2 children, he wrote a letter on our behalf to help support them. So gay men began to realize that we were really fighting for our lives. In 1996, hope came back with multi-drug therapy, change in the meaning of testing. Now, those of us who had been on the let's not test until we know what this is going to mean became let's test so we can get everybody into treatment. And the Ryan White monies became available to help support that, and we then had to shift. And I have to tell you, for me as a psychiatrist, shifting my notions of testing took a lot of internal changes about how to then help people cope with the information that this test would bring, and how to help people stay on medication, since we knew early on that adherence to medication was going to be pivotal for sustaining the effects of this. We needed to think about the change in the public health issue of routine versus voluntary testing. We were asking people to take handfuls of pills 3-4 times a day. Now, let me ask a question. How many of you in the room have been on a 10-day course of an antibiotic for an infection of some kind? Almost everybody. How many people, be honest, had a pill left at the end of 10 days? Look around you. That's less than 95% adherence for 10 days. We want people to be 95% adherent for the rest of their life. Adherence for antihypertensive medication runs 50 to 60%, but it's forgivable if you forget your meds for an illness like hypertension, although there are controversies about that too. What we were asking people to do every morning, every noon, every night was to take their handful of pills and take it, remembering that these pills represented an illness that could lead to death. Now, as human beings, and as a psychiatrist who's interested in the inner workings of our mind, we live our lives knowing we die and pretending we don't. Right? That is a basic formulation of human existence. How do we get up in the morning knowing that at the end of life, when we take our marriage vows, in sickness and in health, till death do us part. At the beginning of a relationship, we announce the end of it. Right? Why? Because we are acutely aware that life is brief, short, and that it's up to us to decide what to do with it. That nobody can bring to it anything we don't bring ourselves. Taking those pills for my patients who had struggled with other issues in their lives that I'm going to get to talk about was a reminder on a daily basis over and over and over again. Women with children would tell us they can't take their pills after school when their kids come home because they don't want their kids to see them knowing that they were sick. So from a cognitive point of view, all of this made sense. From an emotional point of view, there was nothing in the history of how humans are built that would support that this could work. What is remarkable is how well we've done with this in spite of the tendency to not be so good at taking care of ourselves. Since I'm still searching, so here's the question. Is there anybody in the room who has never done anything that you know is harmful to yourself? I'm still searching. This meant that we had to have a difference in the conceptual model of the epidemic. We saw the Lazarus syndrome, literally men who weighed 200 pounds, now weighing 110, lying in bed, skin and bones, going on antiretroviral medication, and within a year, running, looking fit, back to their normal weight. This was a remarkable reconstitution of a body and of a spirit. The chronic rather than acute notion of this illness. And then we had thoughts and talking about eradication of the virus until David Ho finally announced that it would probably take 60 years or more of antiretroviral therapy to even get to the point where we could consider this, since the virus resides in basic stem cell tissue that doesn't get eradicated. But we had these changes in the epidemiology of infection with population shifts. Unlike my generation that was hit from behind from this virus, we now had people getting infected knowing that they were putting themselves at risk. 50% of my generation died from HIV, of gay men. 50%. We now have people who have grown up in the period of HIV, who came out in the period of HIV, who are still putting themselves at risk. How are we to understand this and make sense out of it and construct ways of helping them to increasingly prevent the transmission of this virus? We have done remarkable jobs with infant maternal transmission, clean needles exchange, all sorts of things, but the MSMs, men who have sex with men, remain a high-risk group, higher in communities in the United States among dual minority men, both African American and Latinos, because of the mixed stigma associated with both being gay in the minority communities and with having HIV itself. So the issues, as we come to think about where we're going from here, in the era of ARVs, antiretrovirals, we have new generations of gay and bisexual men emerging every year, right? You know, how many people, when their baby is born, look at their newborn son and say, I wonder if he's going to be gay? Right? We now have AIDS as a, quote, treatable illness. It recedes into the background. When did you see last HIV on the front page of any of the newspapers? A fatigued generation of providers developed wishful thinking. Many of my colleagues rushed to say, hey, we got this treatment, we got to get everybody to take their pills, we're done. Most of us who had been seeing death after death after death tried very hard to want to see that things were going to change for the better. And we have done remarkably better than anybody would have imagined. There is a vast improvement in treatment. But young gay men grow up without the visceral memory of losing their peers, and their impulse is to say, if I get it, I'll take pills. I will be fine. Because they hardly know people living with HIV and dealing with the every single day risk of loss. Here are the issues we're facing. We need prevention. Although monies are drying up for prevention, it's as though now that we have treatment, we want to treat everybody instead of preventing illness. We need to target our interventions to communities that make sense to the people who we're targeting. We must recognize and be able to talk openly about the varying sexual activity and practices of gay men. This challenges normal psychological theory. When I'm teaching sexuality, we talk about how gay men construct their relationships. What is it like? I have to tell you that there are gender differences in how sex is perceived. And I have a colleague who I adore, that she is one of the most loving, open, she works with lesbians and gay men, she's heterosexual herself, she is as non-homophobic as I have ever experienced in someone. And yet when we start talking about multiple sexual partners, when we start talking about things like open relationships, she's the first one to say, I'm not sure I can wrap my head around that. Most people in mental health grow up in a culture of theory that says that true mature sexuality requires a movement from oral, anal, phallic, genital development. That mature sexuality is a dyadic relationship in the context of excluding other people from what happens in the dyad. And that has been the history, we think, of at least the last 200 years. But in fact, the enormous variety in how human beings have experienced sexuality over thousands of years is much closer to what we need to struggle with today. I have studied gay men in dyadic monogamous relationships and open relationships. The reason that we are losing contact with so many young gay men is that we come at them with a model of how they should live their lives, as opposed to asking them how they make sense out of this life and what are their values and priorities and how do they want to construct relationships that have meaning so that they can feel good enough about themselves that there is value in wanting a future life of 70, 80, 100 years. To be protected during sex is to go against everything natural about our sexuality. Think about it. If heterosexuals had used condoms for the last 80,000 years, you wouldn't be here. Right? Unprotected sex is written in the DNA of our biology. It is the normal process of combining male and female to make babies. Gay men, throughout history, never had to worry about pregnancy. Unprotected sex didn't make sense before we began to understand how sexually transmitted diseases occur. Very early on in the AIDS epidemic, I was on the original board of the AIDS Action Committee in Boston. And we were developing our Safe Sex is Great Sex logos. And those of us sitting around the table were kind of like, Now, I do think there is a subsection of people, gay and straight men, who have a fetish for condoms. It's a fetish. They love condoms. Right? It's a rare subset of men. There's even a rarer subset that actually like using them. So what was our task? We had to convince a nation of gay men to use condoms to prevent the transmission of an unseen virus at a time when they felt they had finally achieved the liberation of being themselves. My son would say, does not compute. We were asking people to put off the very forms of intimacy that governed connection in the midst of stigma and isolation. We were asking people to not participate in intimacy in a way that actually might instill hope and future and connection. That we were making every potential sexual partner a potential assassin. Right? Think about what we're asking people psychologically to do. On the other hand, when I would work with gay men, I'd say, this is horrible, it's unfair, and I wish that you did not have to use condoms and could enjoy the freedom. And the only way that's going to be possible is to find someone who's seronegative, who you will be mutually, completely monogamous. You're 19 years old. I don't think that's going to happen this week. So how are we going to help you have what I have enjoyed for the last so many years? Being alive and being sexual. How are we going to give you a future of being sexual? This was the task we faced with people, to be honest with them, and we were trying to convince them that protected sex was great sex. So the disbelief factor on the part of our patients was about 99.9%. Right? And in fact, when we tried to then have discussions about how do we alter sexual behavior, how do we teach people to be safer, how do we teach people to make priority decisions, how do we deal with the inner workings of sexual longings and desire that are complex by the time people mature into their adult years. What turns people on is still unknown. Why people develop their interest in a particular form of sex is beyond anyone's understanding at this time. There's much about ourselves we don't know yet. And yet we have to, if we're going to think about prevention for the future, how do we work with couples where there's serodiscordancy? Okay, let me come back to this. We still here in Canada have, as I understand from the recent materials I was able to get, somewhere about 23 to 4,500 new infections a year. In the United States, the CDC just upped its value to 56,000 new infections a year. New infections. If you went to 56,000 new people in the United States and 4,500 in Canada, and you asked them, do you know how to prevent yourself from getting HIV? Almost 100% would be able to tell you, yes, use a condom. Knowledge has never been more than incidentally related to behavior. All right? How many of you in the room smoke? You know it's bad for you. How many of you ate too many of those croissants out there? Knowledge and behavior are only incidentally related. Because of the way that we think about people, we want to be simplistic about this. How do we deal with secondary prevention now that we have millions of people infected living longer? How do we deal with the fact that all of these people have to learn how to manage this so that they don't give this to someone else? It requires, for gay men, an internal processing of becoming infected. How did they get it? Who gave it to them? Who lied to them? How do we teach gay young men to not believe everything Someone tells them when they're really struggling to want to find community? How do we understand in very small minority of gay men the issue of wanting revenge for having been told by a partner or betrayed by a partner that they were monogamous and not? And how do we understand the projection of professionals onto motivations of gay men? We have said, for instance, that gay men who become HIV positive are suicidal. That's bunk as far as I'm concerned. I think there are gay men who are suicidal, don't get me wrong. But I don't think that going out and having unprotected sex when you're in love with somebody is suicidality. I think the human being has a profound capacity to shut off the executive functions and the cortex of the brain. And maybe it has to do with the blood going to another part of the anatomy that, I don't know, we haven't yet quite understood. But we need to think about how do we talk with serodiscordant couples where one's positive and one's negative. These are people who love each other. How do we tell them, put between the two of you a barrier of intimacy and deny that one of you may die sooner than the other? How do we talk about that openly, compassionately, lovingly? How do we understand that early trauma and problems in attachment have a great deal to do with how people take care of themselves? When I was at the Fenway, we looked at new intakes of HIV-positive people. 75% of the men who had newly seroconverted, this was back in the late 90s, had known histories of early sexual trauma. And we've known this about women for years. There's a tremendous relationship between early trauma in women and the kind of multiple sexual partners, or the getting involved with violent or problematic relationships. And we're finding now that men have issues like this as well. And let me just say, for gay men who came out early, this is even more problematic because of their exposure often to people who would take advantage of them. So let's talk for a minute about adherence. One of the issues you all face, both to protect people who have HIV from transmitting it to other people. We do know that people who achieve undetectable viral loads are less likely to transmit the virus. Doesn't make it zero, but it cuts it down significantly. We also know that medication is not perfect and that people have profound side effects. We know that there are psychological issues having to do with the pre-existing psychiatric disorders that many of our patients, as you heard today, come already with, that were not due to HIV. Unfortunately, what we see now in the population of people with schizophrenia, bipolar disorder, depressive disorders, anxiety disorders, PTSD, are higher rates of infection because of the difficulty in managing not only their sexual behavior, but many aspects of their life without the kinds of resources. I have a psychiatrist who's a social public sector psychiatrist who says we should be giving out condominiums more than condoms if we really want to protect people. Because people who have no place to live, who are on the street, trade sex for safety, for comfort, for cigarettes. We need to understand that psychiatric disorders also precipitate risk factors and behavior. We also know that people have behavioral and emotional fatigue from being protected. What's it like 30 years later to use condoms over and over and over again with different partners or the same partner? What's the increased incidence of mood disorders, anxiety disorders, and even psychotic disorders in the HIV population? This is clearly demonstrated to us from the science and the neuropathology that HIV is a neuropsychiatric syndrome. We know that this is higher in people with pre-existing psychiatric disorders, and we know that HIV causes significant incidence of psychiatric disorders itself. I don't need to tell you all that at the time of seroconversion, HIV gets into the brain, the central nervous system, and it lies there. For some people, prior to the advent of medication, we saw people progress rapidly within a year or 3 years to dementia and death. Dementia was almost uniformly the cause of death in Africa for about 20 years, where people were not being treated for any of the other infections. We also know that we have to think about the impact of living longer with the same disease and the deterioration in the brain. And I'm going to get to cognition in a bit. We also have to understand that recreational drugs and the clear association for sexual behavior. We're not just talking about addiction here. We're talking about recreational use, weekly, monthly, every 6 months. We know that sexual behavior and protection are directly related to taking the cortical part of the brain, the executive function where decisions are being made, and obliterating it. Why do people use drugs? Because it feels good, right? Why do people keep using drugs? Because they get addicted. And then it has a life of its own. But the vast majority, only about 8 to 10% of the population has chronic addiction behaviors. But about 30 to 40% of the gay male community use substances on a regular basis, not to be addicted, but for recreational purposes. And we have to understand what this means culturally, not just personally. What does it mean as gay men come out into a culture where the only place for many years that they were able to be social was in bars? Why was the alcoholism rate so high? It's like the bank robber who said, "Why do you rob banks?" And he said, "Because that's where the money is." You know? Why do gay men go to gay bars? Because that's where the men are. Either that or the armed services. But so we need to understand the use of recreational drugs and the impact that they have on the development of psychiatric disorders, not just on serotransmission. So let's talk a bit about drugs and gay men. Recreational drugs, and now we have this whole category called sexual enhancement drugs. Weekend, you take some ecstasy, some cocaine, some crystal meth, and it impairs your erectile function, so you pop a little Viagra. And you can go all night, all weekend, multiple sexual experiences. Then you use a little alcohol to bring you down, or a little Valium to bring you down. Valium interacts with a little bit of ritonavir you're taking if you're HIV positive. You can see where these interactions alone are problematic. We have these body enhancement drugs, androgenic drugs that bulk up muscles. Because now if you're not 6'2", muscular, and largely endowed, you're not desirable. The images that the Madison Avenue magazines portray go back to when AZT and the first antiretrovirals were being publicized in the gay journals and in things like Positively Aware. And think about the 25 to 30-year-old man climbing the Matterhorn in Lederhosen. Why they had gay men in Lederhosen was beyond me. But here's this young guy, fit as a fiddle, climbing 10,000 feet in the air, saying AZT, Epivir, Combivir, whatever the drug was, saved my life. And these young gay men are thinking, God, he's gorgeous. I want to be like him. Completely obliterating the message of protection and all of what we do. Image, body dysmorphic disorder occurs in gay men at higher rates than among the general population. The dissatisfaction. I sat with a gay couple about 10 years ago. Both of them were like 28, 29. Both of them lived at the gym when they weren't at work. And their body fat was 5% and 4.5% respectively. Okay? Just to give you a perspective, I'm not fat. When you get to 15, 20, 25% body fat, that gets to the people in my age group. Okay? They were concerned about the quality of their relationship because the one who had 5% body fat was developing an obsession that his partner would leave him unless he could lose the 0.5% body fat. Right? These obsessions with body, what we're supposed to look like, what we're supposed to be like, has been the tyranny for gay men and continues to this day. What was it when I was first dealing with the epidemic was the Kaposi's lesions on people's faces, the scarlet letter that identified them as being HIV positive. Now we have the sunken cheeks, the labial folds. Now, I don't know how many of you know, but the Medicare system in the United States just authorized using injections to increase silicone in the face to get rid of that facial dysmorphia so that people could not be so affected by it, because there's a high correlation of depression and the loss of facial tissue. Human beings are exquisitely tuned to facial expressions. And now we also have this rage of herbal remedies, the magical search for cures. Some of these herbal remedies are quite helpful when used judiciously. Some of them also interact with HIV medications. What's very important is to understand that things that grow in the ground are not harmless. And the reason we use things that grow in the ground is because they're not harmless, that they may have good benefits. But I've actually hospitalized a couple of patients with panic disorder who had ginkgo or ginseng overdoses or caffeine overdoses because of the energy levels that they would help with. So we need to think about substance use and abuse, the social context, sexual performance issues, the lethality of combining some of these meds like HIV meds and phosphodiesterase inhibitors, the Viagras and drugs that work like that. Let's move on for a few minutes to cognitive impairment. We know that HIV gets in the brain and that it causes primary concerns. And we also have secondary causes of cognitive changes having to do with infection, like hepatitis C, that also causes cognition, depression, substance use. Here's the system which we now diagnose people with cognitive impairment. I'm just going to spend a moment on it. If you notice on the top left, asymptomatic neurocognitive impairment, we just test with cognitive testing all gay men who are HIV positive. We're seeing percentages of those people with indications that there are deficits in at least one, sometimes two domains of function below standard deviation that are markers for developing cognitive impairment. Asymptomatic neurocognitive impairment does not have known functional impairment. It's a preclinical condition. Mild neurocognitive disorder has mild functional impairment, and then HIV-associated dementia that you heard about 40% of the Casey House population having has moderate to severe functional impairment. We now understand that these are connected. This is a continuum, and what we really want to be able to do is to keep people asymptomatic. So it's very important that we diagnose this condition. One of the things I do as a psychiatrist is evaluate people to see whether they have asymptomatic neurocognitive problems so we could start them on medication. And I'm going to tell you about a quick case in a minute. So we also have to make sure that we understand that acute substance use and treatment and abuse causes cognitive dysfunction, that there's evidence for the growing population of cognitive impairment as people live longer, as people age. There's the impact of the metabolic syndrome, which affects the kinds of internal workings of the vascular tree, of different organ systems. We know that oxygen that gets to the top of the brain is the last place it gets to, and that any of the plaquing in the cerebral arteries can cause slowing and problems. This is what happens with diabetes and multi-infarct dementia. We also know that adherence to medications and problems in this area can lead to resistance and mutation for even more virulent forms of virus in the brain. One of the problems we think is happening is as we treat people whose viral loads in the periphery in their body go down, not all these medications get into the brain with the same successful concentrations that decrease viral replication in the brain. We now have evidence that some people have different viral strains in their brain over time than they do in the rest of their body that are now resistant to the medications that are keeping the viral load in the body down until the virus in the brain seeds into the body and begins to make everything resistant. So we need to understand that this then has an effect on brain function even when the body's looking good. These are long-term issues. The loss of function in the brain increases impulsivity and decreases protective sexual behaviors. It decreases what I was saying before about executive frontal lobe function and the development of coping, and it has to do with the fatigue of the kinds of behaviors that we have to take care of ourselves with. So, unlike what people would like to believe, HIV is still not a benign disease. Although there's hope and promise for continuing treatments, this is a remarkable success of developing medications in the history of medicine. There's a need for more research on treatments for cognitive impairment to get stuff into the brain. And HIV care must be integrated with primary care and mental health care being collaborative, because if we don't preserve the brain, what are we doing? We also need to think about the therapeutic issues. We need to rework with many people their identity as a gay man. What does it mean to emerge in a world today? How does one develop self-worth Internal messages about your devaluation from society continue, even in the most liberal places. Every day I fill out a form somewhere. When my youngest kid was going through school, we had to change where it said mother or father. We crossed out mother, put father, we'd hand in the form. I'd get a phone call. This must be some mistake. No, there's no mistake. We go on over and over and over. We need to understand that we need to help people look at the changing roles within their families when they come out. We need to help people understand the process that their parents and friends will go through. Advice I always give a youngster is, it took you 12 years to come to terms with the, give your parents a few. They'll come around. Give them a few. And if they don't come around, you still have to be you. And that's what we'll work on. How do people manage a sexual life and identity in a new personal and social context? Do you tell people you're HIV positive? Do you tell people you're negative? What if you fall in love with somebody and find out they're positive and you're negative? How do you manage that? How do you deal with that? I'll give you an example of the problems we're seeing more of. There's a 52-year-old man I've been seeing, HIV positive since the mid-80s. He's been asymptomatic. His CD4 count never went below 800, never had a viral load, never been on medication. We called him a long-term non-progressor. 2 years ago, he comes to me complaining about some cognitive problems at work, and my worst fears come to pass, but we do all the testing to try to rule that out. Maybe he's depressed, maybe he's anxious, we do everything. We get him neuropsych tested, and he comes back on testing with an IQ of 137. Pretty good. But his performance IQ was 109. Way different between what his brain could do and what he's now doing. This was the beginning of the cognitive impairment. For the first time, he had spent the first 10 years in therapy with me preparing to die, and finally realized he may not die, and then got on with his life, went back to school, got his degree, and now, 15 years later, he's now preparing that he might be sick and losing his brain power. This has been a transformation over years for him, and we're still working on this. His anxiety is quite high. We got him on antiretroviral medication, but we now know that only some of that medication actually helps. That's just one case amongst many that we're beginning to see in the gay male community that is living with HIV, aging into their adult years. This is what I hear from my patients. Am I lovable? What is my responsibility to my sexual context, to my community? Can I give up this relationship in which I am unhappy but safe to be alone and explore others since I'm HIV positive? Or since I'm HIV negative, I've heard patients say, only somebody who's positive will agree to stick with me because they need me more than I need them. How do we talk about sex and drugs with our patients? Do we? How do we break the traditional models in psychotherapy where we're able to talk over and over again about the most intimate details of people's lives? And how do we prepare to deal with the trauma of finding out again that your life is again at risk? And then the traditional psychiatric symptoms. The longer term issues is growing older with HIV, losing cognitive function, facing mortality. One of my patients, early on after he came back from the Lazarus syndrome and resurrected his body and got back into life, did fine for about 10 years, and then he started to talk about how he's scared that he cannot prepare. How did he said, I'm not sure that I can learn how to die twice. Think about what that means. People have tremendous fears of rejection, adapting to limitations, grieving. We've underestimated the need for grieving in people in general. You know, how do we get on with our lives? How do we let people into our life and let them out of our life? Every year I face losing my residents when they leave. How do we as people bring people in? Those of you who have kids, you know what it's like. Your kid turns 4 and you miss the 2-year-old. Right? You grieve the loss of each part of life that brings something to us. But for our gay men, they're grieving not only for themselves, but for their peers. I believe that although the history of the epidemic is not overtly aware, it is transmitted unconsciously from generation to generation. It's alive in the social context of gay people not having the equal civil rights as their compatriots, as their peers. I can tell you, I was with my husband for 26 years before we got married legally in Massachusetts. And I travel all over the United States and Canada. And the first time I left Massachusetts to go down to Washington, D.C., after being married, I felt different. I don't know why, except that I suddenly thought I was leaving a place where I was okay and belonged to a place that would not even acknowledge that I was married. If I had gotten sick and had been in a car accident in Washington, D.C., my husband of 30 years would not have rights to visit me in the hospital. Now, that made the connection for me about mental health and civil rights and liberties. That if you feel that you are an outlaw in society, if you are not equal to the task, if the expectations are not the same, and the responsibilities, then you live as a subculture your whole life. And that brings certain psychological coping mechanisms to bear. So I think we need to understand this. And I also think the longer term issues for gay people of both seropositive and seronegativity are spiritual and, that should be, existential concerns. Treatment, we've been talking around, dealing with new generations. We need more models for group therapies, social therapies, civil rights. And that's the end of my talk. Let me say that for me, what the epidemic has taught me is that we think we know more than we do, that there's much to be learned about cultures of people, that we have to challenge our assumptions about what does it mean to be gay in whatever context we live in at this point. And how do we as people manage cross-cultural differences? How do we manage difference? How do we not impose our values on other people? As I just turned 60 this year. I know that's really hard to believe. My son wants me to dye my hair. And I said, I earned this. Here you are, here's your brother, you know. But as you get older, you develop an awareness that you know less and less about more and more. That the answers that people would like you to have to make things feel better, be safer, make sense, don't hold water. It has taught me to ask more about what my patients want for themselves, and then to say, and how did you come to want that? Do you think that how you got to where you are is where you want to be, if you really reflect on that? How can I help you decide for yourself? We know that sex and drugs, and in my day rock and roll, were very important parts of who we experience life as. What we have to understand is that we need to make the gay and lesbian community, we need to understand that within the larger society, if we stigmatize people on any level, we will pay a price for that in so many ways. And until we get that message across, mental health and civil rights are clearly, inextricably connected. Thank you, and I guess we're going to have time for questions at some point.